everybody. It's Connor. We are going to be knocking out a couple of short video classes, CEs. Some of them will be worth credit. This is going to be a new medium that we're going to be trying to circulate and trying to get more of a routine down with as far as getting new information out and refreshing on some other stuff. So let's go ahead and knock it out. We are going to be going over a couple of different things. The first little bit is going to be analytics from last year. So all of this is from January 1 to January 1. We ended up with 9 cardiac arrests that we were working, of which we had 2 ROSCs. The protocol deviations that we had 2 of them out of those 9. Now, one of those are mine. But make sure that as we're going forward that we are being diligent with the times, like for our EPIs. Make sure that you're recording them right. Try to stay up on them. Having a stopwatch going is going to be the way to go with all of that. Um, Intubations, we had a total of 18 intubations in our systems. We had 2 failures, that being a missed intubation. The biggest thing with these is that make sure that we're all documenting it the right way. Anytime that you have a laryngoscope go past a patient's teeth is when you need to document video laryngoscopy. Okay, not you went in to get a view and I didn't. It wasn't technically an attempt because I didn't try to pass a bougie or I didn't try to place a tube. Anytime that we have the laryngoscope going into someone's mouth, that needs to be documented as an attempt. Um, for the RSI stats, we had a total of 8 RSIs. We had 2 of those RSIs end with iGel placement, which that happens sometimes. I wouldn't call those failures, but we did have 2 peri-intubation cardiac arrests out of those 8. So that's obviously a very serious complication and something that we're going to be trying to avoid, right? Along with that, we ended up having 3 onsets of hypoxia, that being documented hypoxia either during the attempt or immediately after the attempt, which we want to be trying to avoid as well. Now, those numbers don't reflect the number of patients who were intubated while they were hypoxic this year, and that's obviously something that we want to avoid too. Everybody that's been to the RSI credentialing class already knows that. We need to make sure that we're only intubating people, or specifically RSIing people, once it's safe to do so. So those are just kind of the numbers there. Other skill performance, IV access was 69%. Nice. IO access, we didn't have any recorded IO misses, but we did have 28% of our IOs placed in the tibia. Now, I ignored or excluded the data that was IOs placed by other agencies. Fort Worth Fire shows up, they drop a tibial IO on a cardiac arrest before we get there. I didn't count those towards that number. This is 28% of all IOs started by our personnel were in the tibia, which we no longer have protocols for. So, distal femur or humeral head exclusively. Okay. On intubations, total success rate on intubations was 88%. Again, that's not accounting for any complications of intubation. That's just out of all the times that we said that we made an attempt, how many of them were successful. Now, for the sepsis goal, obviously everybody should know by now, our goal is going to be 100 cc's per minute of transport or 30 cc's per kilo. Okay, and that's for patients that meet the sepsis criteria that we're going to go into a bit later. We only had 27% of our patients with a primary or secondary impression of sepsis meet those goals. Okay, and I was even generous. I said while I was doing this, if you got within 10% of the 30 cc's per kilo, I went ahead and counted that as success. So even that's kind of an optimistic number. Now, 45% of our septic patients got more than a liter of fluid, but with our 30 cc per kilos, like 1,000 might be even a third of what's going to be expected to be given. So that's something that we're really going to need to be working on bumping up. Okay, get bilateral lines, get pressure infusers, whatever you need to do. We really should be working on getting our sepsis fluid goal higher than 27% coming up. Now, 12 lead time, protocol dictates that every chest pain needs to have a 12 lead within 5 minutes of patient contact, and we were at 5.8, so we're actually doing pretty good there. Um, that's the time between the patient contact and the time that the 12 lead was done in the flow chart. So keep that up. Getting into documentation. Obviously, if you didn't document it, it didn't happen, right? So there's been some trends that we've been seeing on QI, and we're going to knock out some of those right now. 12 lead interpretations need to be done in your vital signs. Okay, so you go to your vitals side, you go to your vitals tab, you click on one of the lines, you have all the boxes on the left side. It has a little thing that says ECG. You click on that, 12 lead, manual interpretation, and then your interpretation of the rhythm. And you can choose to write a note about it. You can choose not to. That part you can clarify if you like, but we need to have those in the vitals tab. Okay. Also, make sure that you're completing all relevant forms. Now, some of the forms are going to let you partially complete them. Like, for example, uh, stroke screenings form. If you document TIA or CVA as your primary impression, it makes you fill out the stroke form, but it doesn't make you put in a last known normal or onset of symptom time. If you leave those blank, then it looks like you didn't obtain a last known normal. And when Best EMS looks at our stuff, they don't look at your narrative, they only look at that form. So make sure you're not leaving your times blank in that form. All right. IV therapy. IV therapy is the flowchart item that timestamps an attempt at an IV, either successful or unsuccessful. The total fluid should only be 10 or less whenever you do that. And the only fluid option that we have in there is saline lock. So that was supposed to be a reminder that, this is not to document our boluses. IV bolus is where we go to document our boluses. And then ongoing and prior to arrival interventions, that's going to be you got there and FD had already put a C collar on. You need to put that in your flow chart because if you say the patient had neck pain, but there's no C collar in the flow chart, it looks a little sketchy. I understand that you say it in the narrative, but we really need to have all interventions in the flow chart. Okay. Same thing with ongoing interventions. If you're picking up from another crew or you're picking up from the hospital on a transfer, you need to have everything that is still ongoing. So if they're on oxygen, you put them on your oxygen and take them. That needs to be an event. If they're on a drip, and even if it's not in our medication list, you can do other medication and then put the details in the comments of that. Okay, but we really need to be having that in the flow chart, not just the narrative. Now, stuff that I can't say thou shalt, but would be really nice if we could get better at. For one, is going to be updating our assessments. Okay, not every patient is going to be the exact same from the first time we see them to the time we drop them off at the hospital. So if you need two assessments and you just hit add ongoing assessment and don't change anything, it's going to end up conflicting with your vital signs and or your narrative, and it's obviously going to be inaccurate. So let's try to avoid that. Conflicting vital signs. The biggest thing with that is GCS and orientation. You say that your patient's ANO1, but they have a GCS of 15. We just have to be more diligent than that. Along with that, if you have the SpO2 probe on the same side as your cuff and it gives you like one SpO2 reading of like 70%, but it was transient and like immediately went back to 99, it's okay to trim the fat on that and to uh, get that out of there. That way, you're representing what actually happened with the patient, not an erroneous reading on the monitor. Okay, and then narratives. I'm not saying that you have to write a narrative as long as mine. I know I write obnoxiously long narratives, but don't be afraid to sell your care a little bit. Put your thought process down. Um, Clarify what's in between the lines elsewhere in the chart. Okay, because we picked up a patient who was conscious and breathing. We took them to the ambulance and transported them. Report was given to nurse and unit cleared. I know all of that from from elsewhere in the chart. Like you're not adding any new information on that, right? So couple of quick hits. Ventricular tachycardia. We've had a couple of these last year. Some were treated very, very well, and some were treated a little touch and go. And we had at least one that was failed to be recognized. Now that's not this chart. This is not a. This is a chart from one that recognized it. But a couple of points about VTAC. It's going to be wide. It's going to be fast. Okay, almost exclusively, or dare I say exclusively above 120. Usually I've seen VTAC like 150 to like 200 is a lot more of a common rate that I've personally seen myself. Now, whenever you're looking at it and you're trying to discern is it VTAC or not, here's a couple of things that might have escaped you for paramedic school. I know I didn't learn this until later myself. Your QRS axis, which you can find right here, your QRS axis is going to be between negative 90 and negative 180 degrees. That's very indicative of VTAC. Okay? Your upright and AVR, that's going to be indicative, and your upright in lead V1 is going to be another clue. And then lastly, if you have, and obviously we also have disconcordant QRS and T waves, right? You see that. So you have a negative QRS here, upright T wave. Negative QRS, upright T wave. Then on this side, upright QRS, negative T wave, right? But this last one here is talking about leads V1 through V6. You see how these are all upright? We don't have the normal R wave progression of very little to no R wave in V1, very small V2, biphasic V3, apex V4, and then second and third primary in V5 and V6. So that is what goes ding, ding, ding. This is VTAC. Don't wait for your monitor to say probable VTAC. Okay, you're going to be missing a lot of them. For those of you that were with the talk with Doc, he gave us a tachycardic hyperkalemic patient, and the people that were there know that scenario didn't go very well whenever we were doing it by committee. So here's an example of a hyperkalemic presentation that can present similar to VTAC, but if you know what you're looking at, you can discern pretty quickly that it's not VTAC. Now, this QRS is atrociously wide, and the rate is about 100. So that right there is like, ooh, that may not be VTAC, right? You don't have an upright QRS in lead V1, and you have a biphasic. You have a very small R wave here in V4, and V5 and V5. This kind of notched R wave. This is the T wave that you're looking at here. Sorry, I can't draw very well on my screen. There we go. That's the T wave you're looking at. Here's the R wave. So this does not follow the recipe for VTAC, and also having a history, a dialysis shunt, or maybe they're at dialysis right now, or history of renal failure, history of evacuation, diarrhea and vomiting, can all put somebody into a hyperkalemic state. Okay, so just have an eye out for that and be able to reasonably differentiate, because if we give this patient amiodarone, then we're going to be blocking the only channels that are keeping their heart going, and the next rhythm that we're going to get is asystole. Now, pediatric transport. Okay, this is also something that came from QI. We have had more than a few instances of providers taking pediatric patients to the hospital with no blood pressures or no 4 leads, minimal assessments. Like, look, okay, like a croupy kid who is afebrile and his vital signs are fine. I understand. Like, we just take him to Cook's with mom. It's not that big a deal. But to have the assumption that that's going to be most, or even like a significant majority, borderline all of our kids, that's a fallacy. Okay. Recently, I QI'd a chart where a 3-year-old had a heart rate of like 190, and it's like, look, I'm not saying that's SVT, but like that's indicative of something going on. Okay, like that's not a normal heart rate for a 3-year-old. That means that we should investigate further. Okay, you're not gonna do any harm to a kiddo by putting a 4-lead on them, trying to put an end tidal on them. If they don't take it, they don't take it. I get that, but at least try. Blood pressure monitoring needs to be around the board. Okay, um, I know kids don't usually have issues with their blood pressure, but you don't know unless you check, right? As far as transport considerations, we are getting PD mates or something very much like it. It is dangerous to have a kid ride on the mom's lap or on her chest or whatever. And it's also not very conducive to our assessments or any treatments that we have. Okay? If you end up going with a baby with a car seat or a carrier that you secure to the stretcher, that's safer. But I don't recommend doing that with super sick kids because, again, it's going to hinder our ability to access the patient if they deteriorate. All right, so I'm a huge advocate that any kid that's any amount of sick is not going in a car seat. Okay, personally, I make like a little blanket for it to pad voids, and then I buckle over that, including a shoulder strap, so that they have some articulable, restraint going in all directions. God forbid if that ambulance rolls. Okay, but be on the lookout for some sort of securing device. That's a priority for us. Now, patient assessment. Under the new protocols, it's going to be a breach of protocol to move a patient without an assessment. Okay? This came from Dr. Northeim being an expert witness on a patient who was moved without vital signs through an apartment complex and arrested in the ambulance because they were hypoxic as crap the whole time because they were having a PE. So, before you move a patient, unless it's an unsafe scene or it's immediately life threatening, like a cardiac arrest, that you need to move to a workable area, at a bare minimum, we need a blood pressure, an SpO2. Personally, I consider 12 leads and lung sounds to be on that list. Um, but at the bare minimum, a blood pressure and an SpO2. Okay, so no more patient vitals were obtained in the ambulance. All right, that needs to be those ways are dead. They're not dying, they're dead. All right. Um, and then on the right here, I included a refresher of our sepsis criteria. So pause, go over that, make sure that you know it by heart, and or make sure you know where it is in the protocols. It's under the sepsis protocol. We're having a lot of missed septic patients. Automated blood pressures are convenient, but they are not the end all be all. We've had a lot of issues of charts that have a bunch of trash blood pressures like this one. 163 over 131 is not an accurate blood pressure, especially with a patient who would look like they would be hypotensive, okay? Don't be afraid to rip it off and go to a manual cuff. I do not want to become an advocate for a policy that says that we obtain manual BPs on everybody, but like we can't be having patients who have an end tidal of 14, they are pale and diaphoretic and they look like crap, and their heart rate is tachycardic, and their automated BP says 200 over 160, and the provider went, yeah, that's about right, and never got a manual, or they recycle it and then it says 70 over 30, and they say, oh, I don't like that either, so they recycle that, and and it says 140 over 110, and they're like, oh, okay, yeah, there we go. Like, no, wait, which one of these could possibly be accurate? We won't know unless we get a manual. Okay, so please, please, please make it an effort to scrutinize your automated blood pressures. Now, I've clocked this in at right at 20 minutes. Okay, I'm usually a first take guy, but I've done a couple to get it under 20 minutes. So, um, these are your FTOs, our phone numbers, and our email addresses. Please don't hesitate to reach out to us. We'd be happy to go over anything in the world that you want to go over. Okay. We're not medical control, so don't call us. Don't call us on a call unless it's a transfer and you're trying to figure out equipment type stuff. But um, please reach out to us, and also let us know what you think about this format. Hopefully this is convenient, and like I said earlier, bite size is kind of what we're going for. So yeah, you guys get out there, have a great 2025, and reach out to any of us with any questions. Thanks.